Today is a great opportunity for me to communicate all over Chautauqua County on a very, very important topic. I've read the letters from families. I've seen the impact in our community. Drug abuse and the problems with opiates and heroin addiction has hit every aspect of our community. From the young to the old, from our students to our working families, on every segment of our society, we have got to get a handle on this problem. When I was elected, I heard about the problem of drugs and problems with prescription opiates in Chautauqua County, and so I decided to have a forum. I wanted to bring people together to discuss this very, very important topic. I wanted to educate, I wanted to learn myself, and I wanted to bring us together, whether we were victims of the problem, whether we were treating the problem, whether it's law enforcement, probation, the court system, everyone has a part to play. So I encourage you to spend some time as you view these video segments and to reflect on what you can do, because we're going to mobilize this entire community to get a handle on drug addiction in Chautauqua County. Thank you for your time and attention to this very important topic. In our ongoing segment on our forum on drug addiction, it's important to understand the treatment, those directly involved. Our next speaker has some experience, whether it was on the streets of New York City, in emergency medical treatment. And you're going to hear the specifics of how emergency treatment is delivered here for heroin addicts. Bill Matthews is a physician assistant. He is working with Overdose Prevention for the Harm Reduction Coalition since 2008. In addition to his work with overdose, he's worked in primary care and internal medicine in settings as diverse as hospitals and mobile medical vans. Listen as he provides a very interesting segment on overdose prevention.
I am a physician assistant. I work with the Harm Reduction Coalition, and what we do is work with the state and New York City Departments of Health to promote the New York State Opioid Overdose Prevention Program. And what this program is a recognition that too many people are dying of overdose and that there's something that can be done about it. It's a recognition that when somebody calls for the ambulance for an overdose, too often the ambulance just doesn't get there on time. Very often that call to 911 has been delayed while people present who don't want the police to come when the ambulance comes, and pretty often they do, nearly always, they have delayed that phone call a long time while they're trying all the things they can think of that might revive this person. Only when it's clear that none of these are working do they finally call 911. There is, by the way, a 911 law, as many people call it, that's been in effect for about a year and a half now, that provides that when the police arrive, that they will not be able to prosecute someone based on drugs they find there, up to 8 ounces generally, which is quite a lot of drugs, or the paraphernalia that might be there. It's a complicated law, and it can be criticized in many ways, but it does exist, and the basic purpose of it is to encourage people to call 911. So the state has a program in which they're going to give out kits containing the same antidote, naloxone or Narcan, that my speaker before me talked about, it being a no-brainer to give this out. To give it out, you need not fear prosecution because it's such a no-brainer to use it. Also, luckily, you need not fear any prosecution because if you get these kits through the state program, which I'm really here to promote, you will get, along with the kit, you'll get a little blue card that says you've been trained properly under the laws of New York State. And you'll get a prescription that'll go with it as well, which identifies this kit as your kit. It acts as a label inside. So it is completely legal to use this stuff. It's a little bit difficult to get it at this point. We're working on the problems of insurance companies paying for it. It's just been put on the formulary for Medicaid. This happened just 2 months ago here in New York State. Hopefully when we get to Medicaid and Medicare lined up, that the insurance companies will fall in behind it. Because at this point, the State Department of Health is paying to give out these kits free to anyone who wants it. The way the law is written, when a kit is given out, it has to be given out with that blue card, but also with the prescription. So that means there has to be someone who can write that prescription in the mix. That, at the moment, is the bottleneck. We're working on that. We'd like not to have that, that requirement in place, because obviously it's very hard to always get the physician assistant, doctor, or nurse practitioner, any of those can write the prescription, to get them present when you want to give out a kit. We hope we can find a way around that, but at the moment that's the way this works. I'm up here today from New York City because I hope among you there are people involved in programs that would be interested in enrolling in the New York State Opioid Overdose Prevention Program and become sources of these kits to your clients, to the people who most obviously need them, who will be alone. Well, I shouldn't say alone, because I stumbled into something. You're very unlikely to be able, very, very unlikely to save your own life with a kit. Take an awful lot of insight and as you're going out, to somehow realize what's happening and do anything about it. But as a group of users gather together, perhaps it's going to go through the mind of one of them, gee, does anybody here have a kit? And that's the way it's worked in New York City. I've been doing this 5.5 years, and when we started, and I came in 2 years after this program got started, 2006, the law was written that legalized and really got this program going. But 2008, when I began doing this, part of what I did then, still do, is visit syringe exchange programs, and I'm the physician assistant standing there writing the prescription on the street corner to be able to give these kits out. So I hear a lot of stories, and I'll refer a little bit to them. I also, by the way, work 1 day a week at Project Renewal. That's a company in New York City that runs homeless shelters and I work in a medical clinic doing regular medicine, diabetes, hypertension, 1 morning a week. In my particular shelter, to get into that shelter, you need to have a substance abuse problem. So I see the other side, the medical side of addicted people and dependent people, and how hard it is for them just to take care of their health and stay healthy. We know, for instance, that heroin users, about 2% of them die every year from one thing or another. Overdose certainly is part of it, but just poor health makes up the rest of it. So these kits contain 2 doses of Narcan, that's the old brand name, or Naloxone, and you'll probably find me drifting back and forth between those 2 names as I talk. It's a little vial. There's 1 milliliter. You probably can't see. There's a little bit of liquid at the bottom. There's a lot of air in this vial. And you'll use a syringe to draw it up, inject it into the person, and amazingly, it's a blocker for the opioid receptor, and it will bring this person back very rapidly. If it's a light overdose, they might come back in a couple of seconds, like 30 seconds. If it's a deep overdose, you probably need to go to a second vial, give them a second dose, and it might take 5-6 minutes for them to come around. As I say, this is the same medicine that the ambulance would use when they come. It's the same medicine that would be used in the emergency room. If somebody's brought in, they're unconscious, if there's any thought drifting through some practitioner's mind that this could be an overdose, they give them this drug. It's a safe drug. It's been well studied. It was invented in 1960. Really is part of the campaign to find a medicine that would take away pain and not make people addicted. Along the way, they developed one. When they tested it, they discovered, oh, it actually blocks all the others. And quickly, it's been used in emergency rooms since then. It's also used in surgeries. When somebody's been given an opioid, the procedure's over, you want them to wake up, you put naloxone into the mix. So, how do you use it? So let's imagine we're looking at an overdose. We're present in an overdose. The hallmark of an overdose is that the person's, and we're talking about, by the way, about downer overdoses. We're not talking about the upper, the methamphetamine dose, the cocaine overdose, where the person's kind of flipping out and hyperactive and their heart's going crazy. This, unmistakably different, is that the person's falling asleep. And they're going down, maybe you can wake them up, and they're nodding, and then after a while you can't wake them up anymore. And so, of course, you're going to try to wake them up, and you shake and you shout, and they still don't wake up. Now, I know that the standard of care, certainly on the streets of New York and probably anywhere, is at this point they say, oh, run and get some ice, put ice on his genitals. And so you're running around getting ice. It's not a crazy idea, it's just going to be very slow and the results are going to be a bit ambiguous. So let's say you get some ice and you put it down his pants, and now you wait. And how long do you wait before you decide the ice isn't working? And now you think about calling the ambulance at this point. Or next stage, okay, ice isn't, let's hurt him. Let's really hurt him. And the person maybe they'll wake him up, they'll be black and blue in a day or two. But let's answer this question very quickly. Can we wake this person up? Take your knuckles, put it into their breastbone, and this is called the sternal rub. But it really should be called the sternal grind because you're there to hurt them. Grind your knuckles into their chest, like that, hurt them with it, and if you can't wake them up, that means that this is if you think it's an overdose, it probably is an overdose. You know that you can't wake them up, immediately call 911, or get somebody else to call 911. Now, let's say it's everyone's lucky day, and you have your kit with you. Pull out the kit, open it up, and there are 2 doses of Narcan and 2 syringes to go with it. Now I'm going to show how to do this. Later I'm going to be giving out kits to all. I had hoped to give kits to everyone who wanted one, but the response has been so enormous to this, the attendance here is so much greater than I thought, that I simply don't have that. I've got about 60 kits with me that I can give out. Later, after this demonstration, I'm going to be in the back room just as you are exiting past the registration tables. There's a door to the left, and I'll be in there giving out these kits. I would urge the people who feel they need a kit, that they should have a kit, and you would know who you are, to come and get one. If you think it's just nice to have a kit around to show people, only come please at the end of the day, and we'll see what we have left. We want to get the kits to the people who really must have one. So, you take out your kit, and there are 2 doses in it. Many of you will know how to use a syringe and a vial already. Some of you will not. We'll teach those. We, or I, will teach you. I say we because maybe it's some nurses or just people who know how to do this who will be there to help me. Watch me do it now. This is a little vial of naloxone. There's a top on it. I click the top off simply by my pressure, and the top of this is sterile, so just don't touch it. Now here's the syringe. I'm going to open it. One end has a little open, and I can peel it like a banana. I don't know how well you can see from where you are. There's something green here on the side. That's a safety device. When you're done, you can click it up, you can push it up over top of the needle, and you'll hear a little click as it goes into place. So I'm going to take the top off this now. And again, I don't know if you can see, but this is a really big needle. This is not the needle you want to shoot drugs with. This is going to rip up your veins if you do. It's the last thing you would want to shoot with. It's scary. It's long enough to go through clothing in the wintertime. It's long enough to go through layers of fat to reach the muscle area, which has richer blood supply and will carry this up into the brain and areas of the nervous system where the opioid receptors are. So this is a pretty good simulation now. I'm feeling up here in front of a big audience a little bit nervous. When I get nervous, my hands tremble a little bit. When I'm in a crisis, my hands tremble a little bit. So I could do this the way your doctor does it, kind of like this, right? Except my hands are trembling. And even when I was in school to become a physician assistant, it was clear to me if I was doing this, I was going to stab myself one day. So let's see, what I worked out is I said, okay, I'm going to put the vial on the table. Now I'm going to hold one hand with the other hand like this. Now whatever happens, I'm not going to stab myself. Now I'm going to put the vial down, put the syringe down through the middle of that rubber top. There. I flip it over, and if I start to draw in to the syringe at this point, all I'm going to do is draw in a lot of air, because it's just a little bit of liquid down at the bottom. I've got two methods I can use to get down to avoid that. I can pull the vial up until the tip of the syringe just disappears behind the metal rim. But I'm not wearing my glasses, it's a little hard to see it. So I'm going to try a different method. I'm going to turn it upside down like this. I could still have it on the table, but you can see it better. And I'm going to push the needle right down into the corner. Now I can see the tip of the needle, and I can see the liquid there. I'm going to pull it up, and I could do this with two hands like this. I'm kind of dexterous, so I'm going to do it with one hand. And as you might guess, I've done this before. And I can see the liquid going up into the tip of the needle, just like a vacuum cleaner in a way. At the same time, though, I'm creating the suction in there. I'm going to turn the syringe upside down. Now the air is up at the top. Now I got a moment, even though suction's working against me, I'm racing. I'm going to just pull this off. And I did a great job once again. Now, why doesn't your doctor do this? Why don't I do this when I'm in the clinic? Is that it dulls the tip of the syringe. There's nothing for you to worry about in this kind of emergency. Some of you who are medically knowledgeable know that what you best do is start by pulling back the syringe and right away injecting some air into the vial to create a lot of pressure inside to help you get the liquid out. I'm trying to present this in a way that's as simple for you to remember, because I'm targeting now to the people who don't know how to use a syringe. When you come to get your kit, if you do know how to use a syringe and pull out of a medical vial, just tell me you do. I'm not going to ask you to prove it. I suggest you use the same point of view when you're dealing with your clients. If they claim they know how to do it, just take them at their word. There are, by the way, many shooters, addicts, intravenous drug users who have never in their life used by drawing out of a medical vial. They need instruction in how to do that because it's tricky. There's more air than there is liquid in here, and it's very easy to end up with a syringe full of air. But I've done pretty well. Though I can easily end up with more air than liquid in my syringe at the end. Now you can inject a lot of air into someone when you're giving an injection, despite mystery novels you may have read or something like that. But you'll feel a lot better if you just push that air up near the top. It's a complete waste of time to be tapping it and trying to make little bubbles at the end like your practitioners might. Just get up near there. You're ready for the dose. Where do you give it? So you can give it into, are we live here? Hello, hello? Oh, here we are. Live here. You can give it into the deltoid area. That's up here where you get your vaccinations. That's what is easiest to do. You can give it even easier in some ways. The front of the thigh is the biggest muscle group in the body, the quadriceps. You can't miss it. I say, oh, you can't miss it. Well, then you think, oh, well, I can't miss. But back here runs the sciatic nerve up the back of the buttocks. And this is an enormous needle, and you actually might find that nerve. So it's best to stay away from that area. Just use the front of the thigh or the deltoid. So now I'm going to give an injection. I'm going to give it back into the vial, and that's when you're coming to see me. That's how we're going to do it also. The sensation when you inject through the top of the vial, the rubber vial, is very similar to the feeling of going through skin with a new needle anyhow. So again, I got my trembling hands. I'm going to hold one with the other. When you're doing this with me, don't decide to stabilize the vial with one hand where you're trying to go through. Did it, okay? Now I'm going to give the injection. It's an extremely invasive thing to give an injection if you've never done it before. And you'd probably be like me giving my first injection and going really slowly because this is... And finally the doctor who was supervising me just couldn't stand it. He said, do it! So do it pretty rapidly. Put it in there. So you've given your dose. Now listen. You'll pick up the sound of this click. I don't know if that carried, it was a little quieter, a little bit quieter than usual. When we're doing the demo, please do not click the top at the end. We simply don't have enough syringes. So I'll kind of be supervising. We'll try to pass one syringe on to the next person. We'll try to reuse vials. We're using expired naloxone when we're going to be doing the trainings back there. Okay, so you've given your dose. Now you're watching this person, waiting for them to wake up. So you watch for 2 or 3 minutes. If they don't wake up, get out your second dose. Do not wait more than 5 minutes to give the second dose. Go inside your kit. There are 2 vials and 2 syringes, remember, so now you get the other one out. You do exactly the same thing again. And I look at many of the reports of use that come in. It's extremely, extremely rare for this to be used and for it not to work. It makes you think that in the very rare cases where someone's does not revive, that perhaps they were dead before we start to work on them. When they wake up, if you were to leave them alone, and I know that you're not going to leave them alone, but your clients might, turn them on their side so the tongue falls to the side of the mouth and choke on their tongue or vomit. Keep them stabilized there. Bend the knees down, put the arms out. It's called the rescue position. You may have learned it in CPR classes. So CPR. The role of CPR in this. We're focused on breathing. So let's wind this back, and we're looking now at the case in which not only is this person, we can't wake them up, they're turning blue, and we notice they're not breathing. Now sometimes it's pretty hard to tell whether someone's breathing or not in a case like this. Here's the test I would use. I wet my finger as though to find which way the wind is blowing. I touch it right to the bottom of the nose here. Not nearby, but you actually touch it. And if the person's even breathing slightly, you can feel a coolness on your finger as they breathe in. If they're not breathing, even if you don't have your kit that day, you can give them rescue breathing while you're waiting for the ambulance to come, and that can make the difference between life and death. Here's how you do it. They're on their back, tip back the head like this, pinch off the nose. Now tipping back the head positions, it opens up the throat, opens up the mouth, and it does something also that's quite important. It positions the throat so that when you do breathe into it, it's going to go into their lungs and not into their stomach. So that tilt back is important. Now you make a tight seal of your mouth on their mouth. You got their nose pinched like this. 2 times in a row. And now you're going to continue, but slow. 1 time every 5 seconds. That's hard to remember. Watch my finger. It is. 1 time, watch my thumb, 5 seconds. If you forget that, just remember it's kind of slow. It's at about that pace that you do the rescue breathing. Now, many of you, of course, many of you have had CPR, I would guess. And the American Heart Association had a protocol on a combination of rescue breathing and chest compressions that they changed in 2010, and they said, we're just going to do the chest compressions only. So they stopped the rescue breathing. They still teach it for medical professionals, but for non-professionals, they just do compressions only. Part of the logic was that they noticed that very often, most of the time, people just didn't do chest rescue breathing. No one wants to do it. No one wants to put their mouth on someone else's mouth. Inside your kit, you'll find a little envelope like this. Tear it open, out comes a face mask. It's got a white target. Put that white target's heavy-duty gauze, put it over the person's mouth, and breathe through it. Now you're more likely to do the rescue breathing. It's a little harder to do it. You have to blow harder through the mask. You have to work to keep it in place, and so on. But the American Heart Association made 2 exceptions when they said that rescue breathing was no longer part of the protocol. And that's for children under 12, when it's generally a drowning or a choking, and for drug overdose. But they got very little publicity on these exceptions. So much so that it's common for me to hear stories of overdoses where the dispatcher is called and the dispatcher starts to give instructions. It's all about chest compressions. The chest compressions, which of course come from the American Heart Association, very reasonably, the whole line of thinking is that we're looking at sudden cardiac arrest. The problem is there is oxygen in the person's blood, but the heart's not moving it. So with the chest compressions, you squeeze the heart and you make it act as a pump. But overdose is quite different. The person's unconscious because there's no oxygen in their blood. We're not sure, this is a harsh statement to make, but it appears if in an overdose, if someone's heart has stopped, the odds of saving them just are not that great. Rescue breathing is a complicated subject, so much so that the State Department of Health has convened a committee that's working on it now. It's a group of 20 people, led by my medical director, Sharon Stancliffe, here, and they're re-examining the role of rescue breathing in this. What we're seeing is the benefits of it are not so great that it's an essential part of the procedure, but it's certainly worth trying. So, as I say, that's the difference between the Heart Association point of view. All the CPR guidelines are designed for a heart attack. But it appears that for a drug overdose, it's the breathing component that's key there. Certainly if you know how to do chest compressions, it's not going to hurt to do them. So I think we've covered now how to actually behave in the case of an overdose. I've been very long-winded about this, so let me go back over it in shorter form. A person's nodding, you've come across somebody, you can't wake them up. You're going to hurt them now to wake them up. Knuckles into the rib cage, into the sternum here, grind it in, they don't wake up. You've got your answer in 15 seconds whether you can wake them up or not. You can't, call 911. Take out your kit, syringe and a vial, give them a dose in the deltoid or in front of the thigh. Wait 2 or 3 minutes. They don't wake up, give them a second dose. No, don't wait more than 5 minutes. If they're not breathing, throw rescue breathing into the equation as well. If all things being equal, somebody's not breathing and the kit is sitting right here, I would use the kit before getting involved with rescue breathing. Kit's in your car, maybe, or it's back in your office, the person's not breathing. I would give them those 2 rescue breaths, run and get the kit, and then pick up the rescue breathing from there. Use your judgment. There are many moments along the way when simply you use your judgment. For instance, how deep do you put the needle in? What if you hit the bone? Well, I don't have too much up here, so you'll put the needle in, you hit the bone very quickly. Don't worry. Not only is the person unconscious, but there are medical procedures that are insert the needle until you hit the bone, then pull back a little bit. So hitting the bone is not a horrible thing. So I think I've covered how you do it, right? 911, 1 dose, 2 doses, rescue breathing if you need to, and turn them on the side at the end if you've ever had to leave them alone. So backing up a little bit in this, how does a person get into overdose trouble in the first place? What are the risk factors for it? Risk factors, there are 3 really. The simplest one is not technically it's using alone. Puts you at risk, not of having an overdose especially, not more than otherwise, but it does put you at risk of dying of the overdose that you happen to. In New York they say he caught an overdose. So it's the overdose that you catch. If you're alone, there's simply no one there to help you. Then, next one is using lots of different drugs at the same time. In New York City, the coroner looks in the blood of everybody who dies of an overdose. And 98% of the time finds more than 1 drug there. In fact, it's an average of 3 drugs. Most common second drug found, besides the whole opiate class, which turns up, and the opiates are going to cover methadone and heroin and all the pills, OxyContin, Codone, Percocets, fentanyl, and so on. So those make up about 75% of the overdoses, drugs found. Cocaine, 53% of the time is present. Alcohol, 45% of the time. Benzodiazepines, about 35% of the time. So adding up, so that 98% of the time, and so in the blood of somebody who's died, there's more than 1. Average is 3, they tell me. Now, nationally, in the blood of people who are dying of pills, their death is essentially because of overdoses of painkiller pills or the opiate analgesics, as they're more called in a more fancy way. They find more than 1 drug half of the time in their blood. But using other substances at the same time is a major risk factor. The other risk factor that's of great interest to us here is loss of tolerance. So, and they talked earlier about what tolerance is. how you need more dope to get the same effect that you used to get. So you can lose your tolerance by even going to the hospital over the weekend, in a way you'd hardly notice that you've lost a little bit. Or let's say you go to jail and you come out, or incarceration, you come out even a couple of weeks later, or a couple of months or years later, and presumably by that time you're clean and you relapse. And when you relapse, most drug users know that by the time they're clean, they can't handle the amount of drugs that they used back in the day, back when they went in, so they use less. But if they miscalculate about how much less, they die. Most of the users cannot remember how little dope it took to get them high way back at the beginning. So I was talking on the street corner, telling this kind of a story, how many times I've heard on the street corner the story of the guy who just got out of jail that day, and he came to visit me, and he went into the bathroom, and never came out. And one guy standing there raised his hand and said, "I'm that guy. I went in using 10 bags a day. I came out 3 years later, and I overdosed on 1 bag." He couldn't imagine an amount less than 1 bag that he would use. And so that's incarceration. And for those of us here, I think the big one is you go to detox, rehab, and you come out and you relapse. Why I've come up here today, why the State Department of Health thinks it's worth spending the money to bring me here, is we hope that organizations who deal with detoxing and rehab, and people will join the state opioid overdose prevention program. You can do it if you've got a provider on your staff or some association with a provider who can write that prescription. So you can give these kits to the people who are at risk. They'll take them out into the community. They'll show their friends that they've got them. You'll give them to the parents of the children who are at risk. The terrified parents who know their children are using and don't know what to do about it. Like me, I'm sure you've all read newspaper editorials and newspaper articles about the tragedies of addiction, and the ultimate tragedy of addiction being death, overdose death. And these articles never mention that there's something you could actually do about it. For me, only since the death of Philip Seymour Hoffman am I beginning to see news articles where they mention that there's naloxone, that something can be done about it. Gil Kerlikowski, who's just departed as the president's drug czar, he's moving to another post, but he has advocated that first responders should have this. The DEA is now behind it. All the federal agencies are now behind this. How are we doing on time?
Well, it's pretty good. We've got a couple more minutes to close, and
okay, I wonder if we should look at the slide sorter, and I want to pick out a slide or two to show you. So the question is, how successful have these programs been? So I'm going to show you, can we scroll up, please? I'm going to show you a slide on how well it's done. And of course, I'm pulling out a wonderful slide. And this is going to be, oops, let's see, can we see this one, please? This is San Francisco, and they started an overdose prevention program there. So these are overdose deaths, heroin-related overdose deaths. I want to emphasize they're heroin-related. These kits are being given out at syringe exchange programs. We're not doing a good job of reaching people who are using pills. And I know in this community, it's pills, I think, that are probably much more a problem than heroin, even though heroin is enormously on the rise. It's on the rise, among other things, because the federal and state efforts to limit the supply of pills are successful. There are now registries. It's much, much harder to get pills than it used to be. The classic progression to heroin has always been somebody starts with an injury, or the pills are stolen out of the parents' medicine chest, something like that. Get an orthopedic injury, you're given some painkillers, you take them, and you think it's nice. And you notice when you take two instead of one, it's even nicer. As he said, some people have a particular predilection for it. As you try to sustain your habit of pills, it turns out to be very expensive, and you can't get them anymore. And finally, you discover there's a very reliable opiate supply line, which is heroin. And so you become a user. You probably will start as a sniffer. You may, if you particularly like the rushes, you'll move on to shooting. So we're giving them out to syringe exchange programs. Where do we reach the pill users? Where do the heroin users are all going to show up down in New York at the syringe exchange program. The pill users will show up in rehab sooner or later, in detox and rehab. That's where we can find them. But here's the heroin deaths in San Francisco. Where the arrow is, we start to give out naloxone. And here, I think this is 2010. You see just down to a fraction. Obviously, this is the best slide for showing this. Can we go forward just straight to the next slide? Are you set up to do that? Good, to the next one now. Okay, now here's New York City. Things were going great. Can we go to the next slide? They were going great, and heroin is this line here. So I could talk about how we started the program in 2006, get to 2010. That's a 46% reduction in heroin overdose in New York City. Great. And then this last September, Mayor Bloomberg had a news conference announcing the latest statistics. Heroin's gone shooting back up, especially in Staten Island. And the painkiller pills, which are here, this orange line, they've started going down. So we think what we're looking at is the people who used to be using pills are now using heroin. Bloomberg at the same time announced that among the other measures that police on Staten Island would now start to carry naloxone, which they did start in January. I know they've had their first reversal just a few weeks later. So it does work. And I hope that I'll be seeing people, talking to people who are interested in registering, getting your programs to register. I think nearly everyone here received emails that you can use to get in touch with me, and there's supporting information. One thing they asked me to talk about very briefly is objections. Some of you say, yes, this is all very nice, but isn't it going to encourage people to use more recklessly if they think there's a way to save? It's a kind of safety net. Well, there have been 4 studies that address this, and it seems that people are not using it as a safety net. One reason is that if you're addicted and you get a shot of this, you wake up, but you wake up in withdrawal. It's extremely unpleasant. Nobody wants to fall into that safety net. Right? There are other questions. Can people competently use the stuff? Over 10,000 reversals have been done in the United States using essentially this method. So people are able to learn how to use a syringe. They are able to do it in an emergency. I think I've said everything.
Thank you.
Okay.
Thank you.